So another station from the critical care of Salam Mox is SIADH syndrome of inappropriate ADH secretion. So patient with known lung cancer, sodium is 121 low, plasma osmolarity 217 is also low, which is normally 276 to 295 or 280, and normal sodium level is 135 to 153 millimole per liter. Urine osmolarity is 350, which is high, and patient has a past medical history of hypertension controlled on medication. So what is the cause? Most likely syndrome of inappropriate ADH secretion due to lung cancer. So you should know that causes of SIDH. So primary brain injury, for example, meningitis, subarachnoid hemorrhage, this can also cause SIDH secretion. Malignancy, the most common thing which can happen after subarachnoid hemorrhage is SIADH secretion. So here we have the malignancy as well, small cell lung carcinoma. So small cell lung carcinoma can also secrete ADH and ACTH. Okay, and squamous cell carcinoma of lung can secrete, squamous cell CA of lung can secrete PTH like peptide, PTH related peptide or PTH like peptide, and which will cause hypercalcemia. So drugs, carbamazepine, SSRIs, amitriptyline, infectious, atypical pneumonia, cerebral abscess, and hypothyroidism. These all can cause SIDH. Where is SIDH secreted? Produced by the hypothalamus in response to increased serum osmolarity. ADH. So whenever there is a high serum osmolarity, body will try to conserve water, H2O, and for this body secrete ADH from the hypothalamus. So hypothalamus will secrete ADH in response. So this will be transported to the posterior pituitary, and then from posterior pituitary into the circulatory system of blood. Half-life of ADH 15 to 20 minutes, and rate of sodium correction should be no more than 0.5 to 1 millimole per liter every hour. 0.5 to 1 millimole per liter every hour per hour. So 6 to 12 millimole per liter in the first 24 hours, 18 millimole to or less than in 48 hours. Okay, so why in this manner? Because rapid correction of sodium can cause osmotic demyelination. So if you correct the sodium rapidly, the body osmolarity will go up, and so brain in the brain it can cause osmotic demyelination, previously cause central pontine myelinosis. Investigation for SIDH are blood. So these are the serum sodium low in SIDH, and because body will conserve water, body will reabsorb water, free water, so this will decrease the serum sodium, and so if serum sodium is decreased, then serum osmolarity will also be decreased. You should also do serum cortisol to rule out Addison disease, because in Addison disease there is a decrease of the adrenal hormones. So you have to check for the serum cortisol, because if there is no adrenal hormones, there is no aldosterone, so it also leads to hyponatremia and hyperkalemia, and there will be rash. These are the typical signs of Addison's disease, which can lead to Addisonian crisis then. So cortisol is reduced in Addison disease, so you have to perform cortisol to rule out this, and plasma osmolarity which will be low, sodium osmolarity which also be low, but urine osmolarity will be high, because water will be reabsorbed into the body, and sodium will be high in the urine. TFTs, hypothyroidism is a potential cause for SIDH as well. Urine osmolarity will be high, and urine sodium will also be high despite low serum sodium. Action of ADH. Normally the ADH binds to ADH receptors on the distal convoluted tubules in the kidney. This causes aquaporine 2 channels to move from the cytoplasm into the apical membrane. So we have these cells, suppose, and let's suppose this is the tubule, renal tubule, and these are the cells, apical cells. So when ADH is attached to it, ADH to attach to its receptors, so the aquaporins will go from the cytoplasm into this apical membrane, and there will be these aquaporins too. So they will reabsorb free water into apical membrane of the tubules. These aquaporine channels allow water to be reabsorbed out of the collecting ducts and back into the bloodstream. Results in both decrease in volume and increase in osmolarity concentration. Of the urine. Okay, so urine will be decreased, and concentration will of the urine will go up. Volume of the body will increase, but volume of the urine will be decreased. This reduces serum osmolarity as well. If you are adding free water again and again, so this will decrease serum osmolarity. Okay, so control of ADH is through when will be the increased secretion of ADH, when will be decreased secretion of ADH. So if plasma osmolarity is high, so ADH will be in high amount, will be secreted, and decreased blood volume is in hypotension, like in trauma. Decreased blood pressure, same thing. Drugs, morphine, nicotine, and cyclophosphamide, they can decrease the ADH secretion. MNC, MNC, मुझे ना छेड़ मलंगा. Nausea and hypoxia. These can decrease the ADH. So plasma osmolarity, if plasma osmolarity is decreased, so ADH will be decreased, ADH secretion will be blocked, increased blood volume, hypervolemia, increased blood pressure, and drugs like alcohol, clonidine, which is antihypertensive, and haloperidol. These will decrease the ADH secretion. Thank you.